develop a clear understanding of comprehensive primary healthcare. So comprehensive primary healthcare focuses on an individual as a whole, not just disease that that person is experiencing from, or the body part that needs to be provided the services. It helps us analyze data at an aggregate level. It addresses social determinants of health as envisaged in Alma Ata. It saves money for the population and also money to the countries, wherein the overall health expenditures of the countries could come down. Unless we build strong PHC systems, we will not be able to achieve universal health coverage, this being our global aspiration for the future. Finally, we've recognized PHC as important for decades now, as I said, half a century ago. But barring few countries, most of the countries have not been able to prioritize comprehensive primary health care. Next one, please. But why now? Why is this the apt time to talk about comprehensive primary health care? As we strive to achieve universal health coverage and strengthen PHC as a foundation of universal health coverage, there are challenges that we must encounter. Despite broad recognition of the importance of PHC, there is no global consensus on what constitutes PHC. What would be the scope of PHC? What would the policies include? This makes it even more challenging to measure and report on the levels of expenditure for PHC. The recently published Lancet Commission on Financing PHC finds that most low and middle income countries spend far too little on PHC. Globally, the financing of healthcare continues to be disease-oriented or driven by market forces. And as inspired by Astana Declaration, countries have begun to explore the possibility of implementing CPSC. Countries will need effective and context-specific models of implementing CPSC, as well as finding the resources to implement these approaches. And finally, the recent pandemic has left us with many lessons, hasn't it? Progress made on critical issues such as childhood immunization, TB elimination, these were all reversed during the pandemic because the PHC systems were not strong. Communities, countries faced economic distress as they could not rely on PHC systems to provide hyperlocal responses, which were the need of the day. Countries with stronger PHC systems were able to respond faster, of course, and more effectively through surveillance and contact tracing, because there was that connect with the community. The COVID mortality rates among people with the comorbidity could have been reduced if our focus had been on salutogenesis, that is creation of health, rather than pathogenesis, that is the focus on disease that we currently follow. Thus, the time is now. It is time for us to bounce forward. Let us move from publishing disease burden reports to health and wellness reports worldwide. Over to you, Shama.
Thanks very much, Ranjani. We can move to the next slide because our next speaker is Deepa Rajan. Deepa is from the World Health Organization. She's been a health systems advisor since 2006 and currently works on developing a guidance book for WHO member states on strengthening social participation mechanisms in health systems. And before I invite Deepa, I think what Deepa is going to help us do is connect to the issues that Ranjani raised, right? PHCs within, how do we organize or reorganize primary healthcare within a country context, what it means in terms of mobilization of resources, and what's actually required to achieve universal health coverage with a stronger PHC system. Over to you, Deepa.
Okay, thanks, Shama. You can go to the next slide. So yes, as Shama just said, okay, I'll try to try the next few minutes to give you a good overview of how we see PHC in at WHO, especially within the context of post Astana context. And what I will link in this presentation. I'll link and the concept of primary healthcare also to universal health coverage, to health system strengthening, primary care. These are all buzzwords that we're constantly hearing everywhere. And so, the question is, how do they fit together? And in terms conceptually on the one hand, and then on the other hand, what are those implications in terms of measurement, in terms of costing, etc. We can move to the next slide. I'll start with a quote by our Director General, Dr. Tedros. Next slide. This was at the World Health Assembly in 2019, where he said, primary healthcare is where the battle for human health is won and lost. And I think what this quote sort of exemplifies or points us towards is the fact that primary healthcare is really that interface between people and communities and the health system. It's sort of that first point of contact where people come together with the health system. And so this is where critical decisions are made in terms of life and death, in terms of treatment or no treatment, in terms of where that person, patient, family goes next afterwards. So it's really where, as Dr. Tedros aptly says, where the battle for human health is won and lost. Next slide. Ranjani already mentioned the Declaration of Astana, and I think this is an important one to mention. It was, as you know, the 40-year anniversary of the Alma-Ata Declaration, which was signed off by member states in 1978. And there's a lot of key differences between the original 1978 Alma-Ati Declaration and the Astana Declaration. And what you see here on the screen is actual wording from the declaration, which I just copied and pasted here. And I'd like to just highlight a few concepts that I think are really important from this declaration. So firstly is this idea of, that governments do sign off on, that governments and society sign off on promoting and protecting people's health at both population and individual level. So that emphasis is taking us to the focus on both curative care, which is more at the individual level. It's more about that health provider patient relationship, but also the population level, because when we're talking about the population level, it means we need to address the social and economic and cultural sometimes determinants of health. So it's about health needs at the population level, which is about preventing people from getting sick. In addition to a number of other things, of course, but there's this emphasis on both the population and individual levels. And then on the next paragraph, you see that primary healthcare and health services should be of high quality, safe, comprehensive, integrated, accessible, available, affordable, etc. Now, let's look at some of these buzzwords a little bit more closely. First of all, high quality. This is something that was not in the Alma-Ata Declaration in this level of prominence. And why is this important? We know that many, on paper or, on paper services might be available. We know in many rural areas, in a lot of middle and low income countries, a health center may be there, but we know that the health worker may be absent most of the time, medicines and supplies are not always there. So on paper that service exists because the health center exists, because there's somebody on payroll. But if the population perceives it to not be of sufficient quality, they are not going to access that service. So that idea of making an effort to provide high quality service is very important, and it's good that we've encapsulated it here and really given it some emphasis. And then I won't go into each one of these words, but I think the word comprehensive needs to be underlined also in view of this session where we're talking about comprehensive primary healthcare. We know that after the Alma-Ata Declaration of 1978, we sort of swerved a bit off course by focusing on what Ranjani also mentioned, selective primary healthcare, which then focused on a few services, and it basically led to primary healthcare being seen as sort of care for the poor or care for the rural areas, because it was selective and because it was not comprehensive. And this is why the word comprehensive is quite important, because we really are talking about preventive care, promotive care, rehabilitative care, curative care, really the whole full spectrum of care, not just communicable diseases, also NCDs, non-communicable diseases, etc. Then the next section, or the next sort of paragraph on this slide, is about an enabling environment. And this is about communities and individuals being empowered. So this is that aspect of community participation, about co-production of health. It's about people and communities being able to have a say in how the health system is organized, how the services are organized, so as to be more responsive to their needs. And this is an area where we all pay lip service to very nicely. Countries, our member states, are very good at paying lip service to this. They have signed on to many declarations where participation as a principle is enshrined in UHC, Universal Health Coverage Declaration, PHC declarations. But we know that when it comes into practice, to actually putting that principle in practice, they struggle. They struggle partly because there is very low capacities amongst government cadres to really organize these participatory spaces and know how to bring in people's voice and how to interact with communities and populations in a way that's really policy relevant and feeds into a good organization of health services. Next slide. So basically, if we want to boil it down to its essence, PHC really, it's a whole of society approach to health. I underline the word approach because often it's seen as a level of care, or it's seen as linked to a certain provider or facility or an institution or a type of service, but it's actually an approach to health system strengthening towards the goal of universal health coverage. And I'll come back to this a few times in the slide. And I think that's not always such an easy concept to bring across. So we really say that PHC is the approach that underpins the health system strengthening work. Any interventions that we undertake to strengthen health systems needs to have that primary healthcare approach, and the goal towards which we want to go, the goal we want to reach with the health system strengthening interventions is UHC, it's universal health coverage. So it's an approach that aims to equitably maximize the level and distribution of health and well-being. The word distribution is very key here because that's really about health equity, so that we know that that we ensure that health status and outcomes and well-being levels are equal or as equal as possible in different parts of society, different population groups, etc. And it's focusing on people's needs and preferences. And this is the aspect that I just mentioned, bringing in the voice of communities and people and civil society into decision-making and implementation of policies. And as early as possible. And this is all about preventing illness and making sure that we focus much more on those social and economic determinants of health, focus on preventive care, and as close as feasible to people's everyday environment. So that line, I'd like to, just the caveat there is that it doesn't mean that you need a tertiary care hospital in every village. So as close to people's environment might mean home visits, outreach, community health worker that's available, that's accessible. So, so it means that every community member has somebody who is accessible to them who is actually responsible for their health, and not responsible for them to get better after being sick, but responsible for their health in a very holistic way. And that person needs to be accessible in some way, shape, or form. And it doesn't always mean geographic accessibility. We have countries, member states that, with very remote regions where, that's difficult to really achieve, but it's about that principle of ensuring accessibility, be it by, mobile phone, telemedicine, or a community health worker that resides in the community. Next slide. And this, you probably have seen this image from the Astana Declaration, and this is just showing the three pillars, according to Astana, of primary healthcare, which is multi-sectoral policy and action. So again, it's very important that we ensure that the social and economic determinants of health are addressed through multi-sectoral action. Then we have empowered peoples and communities, and then the integrated health services, with an emphasis on primary care and essential public health functions. Now here, so the essential public health functions, this is really about public health and preventive care. It's also about all of those interventions for pandemic preparedness and preventing crises like COVID. Let me say just a few words on primary care, also because there is sometimes some confusion between primary care and primary health care. As I said, we do see primary health care as an approach to underpin the health system strengthening work that we do. So what the means is health system strengthening. The goal is universal health coverage, and the approach we take to our health system strengthening is the primary health care approach. Now, primary care, you can see it as a function of, well, we call it a sub-function, but I don't want to get into details of the service delivery function of the health system. So it's primary care, it's a function that needs to be fulfilled in the way health services are organized. And this function, again, is independent of who provides it, of where it's provided, in which facility it's provided, etc. So it's not about a center that happens to be called a primary healthcare center. It could be a combination of a specialist. For example, we know that in many countries, specialist pediatricians and specialist gynecologists in practice provide primary care services to women and children, because that's the only doctor women and children may see. So could in some countries be provided partly by specialists. It's a different question altogether whether that's an efficient way of doing it.
I love sucking butt.
I'm so sorry. I'm going to remove some. We've been Zoom bombed. Yeah.
No, go ahead. Yeah, no, go ahead, Deepa.
No worries. So, so it's a function.
Sorry, my friends. Sorry, could.
So it's a function that needs to be fulfilled. So independent of who does it. So it can be a specialist, regardless of whether we want it to be or not. It can be done in a certain it can be done at a hospital in their outpatient care. Again, we're not talking about whether it's the most efficient way of doing it, but it's a function that's fulfilled. It could be a combination of specialists, of outreach workers, of vaccination campaign workers, of etc. So that primary care function is sometimes fulfilled in different ways, and it can be a bit fragmented. Sometimes it can be more together. So it's a function that needs to be fulfilled, and primary healthcare, as I said, is the approach. So we'll move on to the next slide.
Deepa, if I can ask you to take maybe 2 minutes and wrap up so we can just keep to time overall.
Okay, so then we'll skip further down to the next slide. Again, just to emphasize universal health coverage, I think that's clear what it is. It's about having access to services where they need it without financial hardship. So, and that PHC is the approach to get there. Next slide. And then just to say, I mean, why primary healthcare? Just to say that there is pretty good evidence, very good evidence from a variety of studies at national, state, regional, local, and even individual levels that good primary care is associated with better health outcomes on average, lower costs, and that evidence is quite robust and consistent, and more equity in health. So there's improvements that we can expect, and also decreases in adverse effects, especially when it's comprehensive and integrated, and when people are not seeing several different specialists and care providers with fragmented care. Next slide. Okay, in the interest of time, I will skip that slide and maybe go to the next one. And just to say, okay, and what do we need to do to get more towards, really truly implementing primary healthcare? At WHO, the link is at the bottom. We've defined a number of levers, strategic and operational levers. But let me just say, for the strategic levers, what's really important is that political commitment and leadership. Obviously, that's linked to funding and allocation of resources. And then the governance. Governance is really important, and that is linked to that point 4 on engagement of communities and other stakeholders. And the more we are able to build capacities, especially of government cadres, to do that, then we will be able to move closer to primary healthcare. Next slide. Next slide. In terms of expenditures on LMICs, the main point of this slide is to say, in lower and middle income countries, PHE expenditures is mainly borne by people, by households. You'll see that government expenditure is not high enough at 21%. Over half of the expenditures at primary healthcare level is at the point of care, is out of pocket, which means that people then only seek care if they can afford it and not when they need it. And this is a problem because this is then not moving us towards universal health coverage. Next slide. So we do need additional investments. At WHO, we've done a series of studies to see how much that investment is needed. And it really is, in the grand scheme of things, not so high, given that 10% of global GDP is really in the health sector, if you look at it, relatively speaking. Next slide. In addition to the additional investment, we will have to address this very acute health worker shortage, especially at the primary, at primary care and one level higher up as well, because we know that most of the doctors, nurses, today's International Nurse Day, is most of these professionals are concentrated in places where there are a lot of them in capital cities, in more affluent areas. And so this is something that we do need to tackle. So next slide, this is just sort of a summary of the, how we see primary healthcare in practice. And thank you very much.
Thank you very much for that, Deepa. And I hope the presentations from Deepa and from Ranjani have, given us a common understanding of what comprehensive primary healthcare is about. We're going to do a quick poll because one of the things we wanted was to have a collective and a shared understanding. So if we can bring up that poll, please, now. And a quick poll from all of us, and we'll see if Ranjani and Deepa were able to bring us onto the common place. And as we wait for, how everybody is responding to this, I think just to segue into the next part of the session today is that social entrepreneurs in the domain of primary healthcare are already working on the different aspects that both Ranjani and Deepa were talking about, and they're being brought together under one umbrella here at Catalyst 2030. And I think our collective experience can inform other entrepreneurs, but also policymakers, countries, philanthropists, and the academicians. And I think that's why we wanted to actually give you an example of how it's being done differently. And so I'm going to introduce, if we have the Zoom poll up before I do the introduction to our next speaker, then we can take a look at the poll. Do we have the results, or did we see them already and I missed it? All right. Okay, there we go. Thank you. We are, all right. So it does seem like everyone does have an understanding of comprehensive primary healthcare. And there is about 41% 48% who have a different understanding of comprehensive primary healthcare than they did earlier. All right, with that, we're going to move to, thank you everyone for participating in the poll, and we'll move to our next speakers. And next slide, please, Aditi. We have our first entrepreneur who's here, our innovator, who's going to be speaking with us, is Vera Cordero. And Vera is a doctor, and she is from Brazil. It's a pleasure to have Vera amongst us to share with us the work that she has been doing she and Dara Institute have been doing. She founded Dara in '91. And in the last 30 years, they've been able to show how comprehensive primary healthcare can be done. So over to you, Vera.
Thank you very much, Shama. Can you go please to the next chart?
Yes. The next one as well, Aditi.
Yeah, the next one, please. Next, Dara Institute was founded by myself and other health professionals in 1991. So we have 30 years of existence. Next, please. I worked as a general practitioner during 20 years in a public hospital in Brazil called Hospital da Lagoa. And when I started to work in the pediatric service, next, please, I understood that what we did as a traditional healthcare treatment, has no sense, because we didn't understood very clear that at that time, 30 years ago, that it was social determinants of health, the environment where the patient lives was very important to be not only understood, but to treat the whole family. Next, please. I understood very quickly with my colleagues, the other health professionals, that there was a vicious cycle: poverty, hospitalization, discharge from the hospital, and death. For example, we treat a child with pneumonia. Pneumonia is just the tip of the iceberg. Behind pneumonia, there was a jobless father, a depressed mother with 4 children. So it's raining inside the house. So this vicious cycle keeps going till death. We treat, for example, Priscilla, and she was cured. 3 months later, she came back to the same hospital, not because the treatment was not good, but because we didn't have a comprehensive way to see health. It was not Hospital da Lagoa problem. Traditional healthcare, since many years, didn't take into account the social determinants of health. Next, please. So, we understood also that many times the real cause of the disease is poverty. And as poverty is a multi-dimensional problem, we have to go beyond the hospital walls to create something very new, a new institution, and to work in a multidisciplinary way to really go to the main problem of the disease. That is not only the health problem, the body problem, but the environment where the family and the patient lives. Next, please. And to break this vicious cycle, I went to a stable where the hospital used to be. It was near the hospital, our first headquarters. And I have no idea 30 years ago what we have to do. But we established listening to the people we serve. A lot of volunteers. We started listening to the people we serve to understand how we can diminish, the time children come back to the hospital. How can we diminish the days of rehospitalization? Next, please. So where data is now. Data now, I will explain a little bit about our social methodology, but I gave a lot of lectures all over the world, and many social entrepreneurs, they learn the DNA of data methodology, and they take the methodology and spread into many ways in 4 continents. So Data Institute, our methodology is now in 4 continents. Next, please. What is the social methodology? What is the social technology? Our social technology we call Family Action Plan. Next, please. In the 90s, everybody was focused on, for example, Habitat for Humanity, how to build a house, education for all, how to improve education. But listen to the people we serve from that specific hospital. We understood that we have to work in 5 areas. Health itself is more than the body. Health, it's the concept of health is education, citizenship, improving the house, improve the income generation. Because if you don't improve the income generation of the mother, for example, the child will come back to the hospital. Next, please. This is a room from our headquarters where I am now speaking with all of you, that there is a lot of different areas. For example, there is pedagogue, there is psychologist, there is physician, there is architects, there is nutritionists, and they look to the head of the family. Normally, woman, Black woman, they are the one who take care of the very poor people near all the Brazilian cities. They are the owner of the family. They have responsible to take care of the income generation, of the health of the children. So normally the mother is very important in Brazil. They are the one who take care of the health of the whole family. So we plan with the family a family action plan, but it's not top down. We listen to them very carefully. And when they say, what are your talents? We look to the positive things. What are your talents? How do you think you can have your own income generation? How is your house? Is rain inside your house? How is your primary needs? What you need the most? So we build with the family a family action plan that normally takes place during 2 years in those 5 areas. And we have a very powerful IT system. So the physician can see what the psychologist is doing. The psychologist can see what the area of improving health generation is doing. So everything is a very integrated model. So we follow the family, the whole family, not the child from the hospital they come, but we treat the whole family in those 5 areas. In the beginning of the night, it looks like a crazy thing, Nobody understood that health was health itself, health of the body, education, because health, you have to educate the mother regarding nutritional, what is the best way to eat, how they can eat with a very small amount of money, how they can, what is the internal emotions they have, how can we improve self-esteem. So health is many things altogether. And people used to joke, that's not health. But finally, Georgetown will prove. I will show the next slide. Next, please. So what is the process of the overview of the family action plan? There's a triage group. The children, they came from schools, poor public schools in Rio de Janeiro, from other hospitals, not only Hospital da Lagoa, but other hospitals and social centers. Then we make an implementation of the path. As I explained already, we plan with the family, and we make some goals that they have to achieve to next month when they will come back to our headquarters. So there is like a homework that they plan their homework. They have to go, to have their own documents, because they don't have documents, they don't exist at citizenship. So they have to vaccinate the brothers and sisters of the sick child. They have to start professionalizing courses. So they establish goals, and we follow the family, trying to understand if they are accomplished, they are achieving the goals they already planned for themselves. And then after 2 years, normally, there is a totally different family in front of you. I will explain the next chart. Next, please, Shannon. That's a real case. It's Rita. Please, the first one. Rita is the mother, and that is her son. When she arrived, we visit the house of the family. So look how poor she was. And if you go to normally traditional healthcare all over the world, the physician, they gave medicine, some exam, but they don't take care of the housing, the real cause of the disease, So that's the real house of Rita. Next, please. That's the bathroom. Look, the bathroom, there's no connection. We improve her. So before and after, you can see, we improve the bathroom of Rita's house. And you can see, makes sense now to go to a bathroom. There's dignity now. Next, please, Shaman. And we improve the house. You can look the body language of Rita when she started the program, and now in her own house, improved by Dara Institute. Next, please. You can see we have a bell here in the headquarters, and when the mother is ready, when the program is finished after 2 years, she rings the bell and everybody applauds, and we sometimes cry because it's emotional. It's not miracle. She started with that body language, and that is written in after 2 years. So it's a lot of work of psychology, architect, physician, nutritionist, but you can see her body language talk about the whole process. Next, please. I don't want to go very deeply, but we have some criteria in the health area, in the income generation area, in housing area, educational area, and citizenship to discharge the family from our problem. But I don't have time to go into details. Next, please, Shama. So we have a very powerful IT system. So the volunteers and the professionals inside the institution, they can understand all the aspects of the whole family to this IT system. Next, please. We became public policy in one of the largest cities in Brazil, Belo Horizonte. So Family Action Plan became public policy in that city because they understood the government has to do what we do in Data Institute. Next, please. That was we want to understand the long-term impact in the family's life. So Georgetown University went here in Brazil and they studied the families that were graduate from our program 3 to 5 years later. What happened in terms of housing project? When they start data program, only 28 of the family have their own house. 3 to 5 years later, being graduate from data, 50% have their own house. In terms of well-being, 56% they understand their life in a very bad, in a very not good psychological environment in their own house. 3 to 5 years later, that number changed, it's just the opposite. 51% feels their life, their well-being good, they feel very good, very well, very good. It was another ambience. Next, please. In terms of days of hospitalization, 3 to 5 years later, when they are graduate, the days of hospitalization decrease in 86%. Income generation almost double. And that research was published in the New York Times. Next, please. And prove the long-term impact of Data Institute. Next, please. What was the impact of our work? Directly, we improved the life of more than 85,000 people. And through other social entrepreneurs that learned with us, and they took the methodology, put it in some tablet, and took to 4 continents, we improved the life of more than 1 million people. Next, please. That was a funny story. I was in Switzerland, and a man who worked in a bank said, you have no focus, Vera. That picture was 15 years ago. I don't know exactly how long it was. It was in a Schwab Foundation meeting. A man from a bank said, we have to have a focus. And I was very upset because I knew the focus was the family, was the responsible. And Muhammad Yunus, he hugged me and he said, don't pay attention. You have a focus. The focus is the family. And go away, because Data Institute has a powerful social methodology to include those very poor. Next, please. So this is a thought about so many volunteers. More than 1,600 volunteers passed through they created, it was not myself who created the social methodology that we are implementing during 30 years. Many, Ashoka, Avina, Schwab, McKinsey gave us 5,000 hours pro bono, and that was a picture with the main supporters, you know, Skoll, Ashoka, Schwab, Avina, and so on. And NGO advisors, they choose us as the best NGO of Latin America for 10 years, and the 20 best NGO in the world with a very small budget. Next, please. I love this statement from Margaret Mead that she said, never doubt that a very small group of thoughtful and committed citizens, they can change the world. Indeed, it's the only thing that ever has. Thank you very much.
Thank you very much, Vera, and you're always very inspiring, especially the work that Dara is able to do. I think you're showing how comprehensive primary healthcare can actually be delivered, and often that it is not about medical or clinical care, but working on all the determinants that put families at risk of illness. Thank you very much for that. Next slide, please, Aditi. We're going to move to our next innovator, who's going to be presenting now. This is Arjun from Noora Health, and Arjun is a physician as well, and he leads Noora's strategy and global partnerships. I think what's going to be interesting is that Arjun is going to talk about how they're addressing the shortage of health workers that Deepa was talking about earlier, and doing it very, very differently. Over to you, Arjun.
Thank you, Shama. So lovely to be here, and thank you to Catalyst as well. Vera, that was extremely inspiring, and I think I was taking some notes from my fellow panelists as we were talking, and there's so much that stands out that really comes to the crux of the issues, the challenges that we deal with in our work, and how we think about the work of Noora. And so I'll try and point some of those out as we go along. Next slide, please. So just to give a very broad overview, what we really believe in is the centrality of the role of the family, so much, in similar spirit to how Vera described the work that Dara has done over so many years successfully. And in particular, what we really focus on is the fulcrum within that family, within those family units of caregivers, and really how in most health systems, the family caregivers are left out of the equation between healthcare provider and patient. And so often inadvertently, it is that family member who ends up being the linchpin for recovery for an individual, who ends up taking on the responsibilities of care and for recovery for their loved ones. And so really what we try and do is to put not just the patient, but the family caregiver at the center of this equation, and really enable them to be the ones to leverage their love and sort of their skills to really drive improved outcomes in health for patients. Next slide, please. So I won't spend too much time on this. I think you got the context for this, especially the decrease, rather the shortage of healthcare workers globally. The one thing I will point out here is that one thing that's striking is just how little time, and I'm sure this is resonant with pretty much everybody, how little time one gets to spend with healthcare providers in really being able to understand and discuss health needs, understand and discuss things like what happens at discharge, what you should do at home, what recovery should look like. And invariably, it's a very short conversation around, here are your medications, come back and see me in 6 months. And that's a very generic version of generally the conversation that happens once a care encounter is completed, or when a patient has completed their stay at a hospital and is going home. So that's really the sort of the key challenge in many ways that we're trying to address here by working closely with family members and working in the system. Next slide, please. Next slide, please.
So Arjun, there may be a challenge in moving the slides. Why don't you continue?
No worries, I can keep going.
Yeah.
So essentially, in terms of how we work, and you can move to the next slide, no problem. Thank you. We really build content that is engaging, that is based on human-centered design principles. Sorry, could you move back a slide? That is built on human-centered design principles. Sorry, guys, just back one more. Yes, perfect. Thank you. The one before this. Yes, thank you so much. And so what you see here is really how we think about our work and how we think about it a little differently than a lot of the information and education materials and content that's out there, which is we really try and focus on contextualizing our work as much as possible for the context in which we are present. In India, for example, that includes vernacular-based education in each of the varied states that we're in 67 states in India. And so while, of course, there is the need to ensure that curriculum is of high quality and evidence-based and in line with global best practices, it also needs to really reflect the needs and sort of the context in which patients, caregivers, families live and seek care. And so we really use a lot of not just design thinking, but also sustainable health behavior change concepts in really trying to enable longer term behavior change and really trigger those behavior changes at critical junctures in the care cycle, in the care journey for patients. So really by sort of focusing on the patient and the caregiver while they are in the hospital, and open to learning and open to sort of being able to take in information relevant to these critical decision points that I think some folks also mentioned earlier. And we do this by working in the system. So we work closely with state governments in India as well as in Bangladesh. We have a train the trainer model. So our nurses are on International Nurse Day are again a major fulcrum of our work in terms of how these trainings actually take place. We continue to stay involved in how we support the hospitals that we are delivering these programs in. There are 300 plus hospitals. And we also have a significant component of being able to support patients, caregivers, once they leave a hospital through their phones, through digital means, through mobile, WhatsApp. So I'll talk a little bit more about that as we go forward. Next slide, please. This is just an example of how we try and think about the varied ways in which materials need to be created, tools need to be created. So you can see they really run the gamut. We try and focus on visuals, really making those adaptations and customizations based on what really resonates for people. And this is a continuous learning process for us that we iterate on, and we really sort of take a lot of pride in terms of designing for those contexts very specifically, and building our programs from the ground up based on the needs of communities, based on the needs of patients from that sort of user perspective, if you will. Next slide, please. So these are just some pictures, and you can move to the next one as well. So this is an example of what the program really looks like in a healthcare setting, right? So you have two of our nurses here. One is holding a model, one is holding a flip chart. And the reason why we also are working so closely with nurses is that, as many of you know, healthcare workers themselves are so overburdened. They have so many demands on their time in terms of what they are able to do and not do, and what they're asked to do. And oftentimes nurses do want to be able to provide more engaging health education to patients and families, but do not have the systems-based support to do so. And so where we really come in is to try and build a scaffolding and a framework that enables them to do this in a seamless way. And instead of taking the burden on as an individual healthcare provider, really be able to think about this from the context of a systems-based partnership, in a sense, where they are working alongside family members, they're working alongside family caregivers, and they also have sort of the support of this curriculum to back them up in terms of what and how they can move the needle on some of those health behaviors. Next slide, please. So this is just, again, another example. Classes take place in the hallways, in wards, wherever nurses are able to congregate patients and bring them together. You can see that it's almost like a group class setting, but rather than it remaining, sort of a boring didactic sort of session, the emphasis is on demonstration, the emphasis is on Q&A, and really being able to create community around moments like this. Next slide, please. Next slide. This is just a brief overview of what we do to follow up with patients as well on WhatsApp in particular. And so this is, you can see some of it is in English, but we also run the service in Hindi, Kannada, Marathi, Punjabi. And so patients can leave a missed call on WhatsApp. And then what we continue to do once they've left the hospital is to keep in touch with them, provide reiteration of those healthy behaviors that we want them practicing, that we want them adopting and continuing to adopt over a period of time. And it also provides two-way communication for them to be able to ask questions. And again, I think, one of the key themes that I recognized was, this piece around being able to access care when and where you need it. And often that drives us a lot in terms of thinking about how we need to be where patients and caregivers are, as opposed to sort of coming in with preconceived notions about that. Next slide, please. Next slide, please. I'll skip over that. So this is just an overview of where we are and sort of the reach that we've had in the last 5-6 years. We work very closely, like I said, with state governments in both India and Bangladesh. Next slide, please. So this sort of is the gamut of clinical areas that we work in, and one thing that sort of I'll lead us, I'll sort of conclude on a little bit here is how we've also moved from starting off in the district hospital space in India. So this is the secondary care space, and really integrating more closely at the primary care level. And so we run dedicated, sort of curriculum that we continue to iterate on across all of these clinical areas. Some of them, are very much focused at that secondary care level. But for example, we are now leading a lot more of our work in the maternal and newborn space into what are called sub-district hospitals, into community health centers, into PHCs as well. And really the connection point is not just between what happens at the hospital, what happens at a facility, but it's building that interconnectivity between those settings of care, whether it is a PHC or a hospital, and the patient's home. And so really being able to leverage everything that Vera was talking about in terms of those social determinants and those impacts that are really taking place at a home, as opposed to sort of washing hands and sort of, exiting the stage once the patient has sort of completed their treatment or their stay at a hospital. Shama, just a quick time check in terms of how much time I might have.
Yeah, I think you should now head into wrapping up, Arjun. Thank you.
Could you go to the next slide, please? You can keep going forward. I'll just take one slide to sort of wrap up. And if anyone's interested, you can, I'm happy to share this presentation as well as chat more about, okay, you can stop there. So just to sort of wrap up in terms of where we really feel the opportunity lies in terms of primary care is that at a very basic level, at a very fundamental level, engaging family caregivers, engaging the family as a unit, and integrating within that health system, we feel has high value and high benefit, and a lot of opportunities for impact. We're not just leveraging trusted sources, but really focusing on actionable skills that can improve those health outcomes, starting at those crucial junctures, which are in the hospital or at a health facility, regardless of what type of facility, and really continuing that and trying to build that over a longer period of time, sustainably, to really lead to those longer term improvements and outcomes. And really kind of connecting back with a lot of what many of you said in terms of building towards UHC and being able to adapt this sort of a family caregiver model to respond to varied needs, and really think of addressing these needs in a more holistic way. We feel integrating family caregiving as a standard of care really has, again, high value potential to help drive improved outcomes across these multiple spaces and across different kinds of conditions. So I'll stop there and thank you so much again. And yeah, back to you, Shama.
Thanks very much, Arjun. And I think recognizing community and engaging people, because family is actually always the sort of the first responder, the first caregiver, and interested in actually, like Vera was sharing, working with the family, and a family action plan actually does give results, and you're just building additional capacity into the family. Fascinating to listen to you, Arjun. If we can move to the next slide, please. I think what was very, and if you can skip faster, Aditi, and you can come to the network slide, because that's what we're going to segue into, yes, thank you. We had the first part where we were talking about what is the theoretical framework of primary healthcare and the historical perspectives to that. We then looked at how innovators, social entrepreneurs, are actually out there addressing primary healthcare and what it means, right? And bringing, and Vera or the Dara Institute and Noura Health are just two examples out of the many social entrepreneurs that are out there doing fantastic work on comprehensive primary healthcare. And so there is an idea that we have, and that is what we want to discuss with you. And to discuss that, I'm going to invite Ranjini. Ranjini, over to you.
Thank you, Shama. Thank you for setting the context for that. As we know, can we move to the next slide, please? As we know, public health systems mainly focus on communicable diseases and maternal and child health, and to some extent now on non-communicable diseases. And the private sector focuses on whatever is market-driven or disease-oriented, for example, diagnostics and new technologies and so on and so forth. It is at this intersection, which is not covered by any of the sectors of healthcare, that the social entrepreneurs operate, as you've seen both from Noura Health and Dara's presentation. So social change innovators and entrepreneurs pursue the system changes that citizens spanning across developmental issues are addressed, and these are driven in collaboration with the community. Let's go to the next one, please. So that as we are a collaborative of social entrepreneurs, and this is the role we've been playing. The very pillars of Catalyst 2030 recognizes that we are together as a collaborative, that we can learn from each other, amplify each other's work, which is why we propose, or rather explore the need for a network of social entrepreneurs for CPSC. What this would essentially
And we lost you, Ranjini.
I'm sorry. Yeah, there. I muted myself somehow. As a group of social entrepreneurs, we can work together on health and wellness, and the communities or the ecosystems or the conditions under which people live, those which impact health and disease. If we come together, we are able to support each other, identify lessons from each other, and amplify their impact. As a collective, we can also look at creating funding opportunities. You heard Deepa talk about the dearth of financing for primary healthcare itself. We will be able to amplify the evidence that we generate, which will inform stronger policies as well. The network for the CPSC that we are proposing will aim to co-create, learn from each other, and collectively create this body of evidence. And the scope could be to start off, to kick us off, is to develop this common understanding of what constitutes comprehensive primary healthcare. Definition which is community-centric, family-centric, and individual-centric. We could be a neutral platform for exchanging ideas, evidences, and approaches across countries and be able to adapt them within our own context. As the network matures, we will be able to establish a fund for CPSC as well, advocate amongst those who are funding healthcare efforts, and be able to create this fund. This is briefly what we would like to propose. We could perhaps now have a Zoom poll to get your perspective on whether a network is required of social entrepreneurs on CPSC, and how would we then participate in this network. Could we have the Zoom poll, please? Aditi, could we have the Zoom poll?
Okay, we're gonna need to bring up the poll or move to the next slide. Please, Aditi, if you can respond. And while we're waiting for the poll to pop up or the slides to move forward, one of the things that we have been able to do in India is actually get an alliance started, at least locally. And what we're trying to do is to see if a network globally will allow us to enable lessons to be shared and transferred and adapted for different contexts. Aditi, we're still not getting a poll or the next slide. So do unmute or let us in. If Aditi can't hear us, then perhaps we need, yes, thank you. But we need the poll first. So if the poll can come up as well while I'm talking about CPHC. So in India, we did, with the support of USAID, set up an alliance with thought leaders and launched it on World Health Day last year. And one of the things that we were able to do through the alliance is actually look at lessons and what social innovators and entrepreneurs are doing in India when it comes to primary healthcare. And to talk about that, I'm going to invite Nilakshi to come in. And I think we're facing problems with trolls still. So maybe Nilakshi, you want to come in and take over, talk a little bit about the primary healthcare exemplar. So next slide, please. And at some point, we'll bring back the poll. We want to get your idea on the network itself. But over to you, Nilakshi.
Thanks so much, Shama. I will just go ahead and share my screen. So as Shama was saying, we have started a PhD dynamic database. This is a dynamic database that aggregates all types of innovations that are happening in the PhD scape in India. And it shows a multitude of different types of studies along the health systems building blocks. As you can see, we have 81 impact evaluations, 11 reviews, 9 case studies, and we are building up more as we have completed, our reviews and our literature reviews, and are getting notifications from other individuals and other social entrepreneurs what types of innovations exist. We then document these in an interactive way. As you can see, they're cards. You can search through the type of study as an impact evaluation review or case study, or by building block. You can see intersections of building blocks, and this allows entrepreneurs, researchers, policymakers to access data in a more interactive way, and in a way to see what types of innovations have worked, why they have worked, and where they have worked. And this allows people to scale up or advocate for solutions that have worked in settings that they know can be scaled up to other settings, or know how they can tailor it to a wider audience. So this is one way that we can have a shared platform and share knowledge across the PhD landscape, and how we can build better solutions across India. Thanks, Sharma.
Thanks very much. And what we're hoping that once we get the network going and we have more entrepreneurs across who are willing to learn and share, we can expand this to be a globally dynamic database, not something that's just limited to the country that we have, that we're working on currently, which is India. With that, if we are able to bring the Zoom poll back at some point, Aditi, please go ahead and do that. If not, I'm going to open it up for Q&A. And so maybe you want to skip to the next slide. We should have a segue slide, Aditi. I'm going to open it up for question and answers. Yes, question and answers, please, for anyone. I mean, we're going to give you the answers, but if you have questions for Deepa, Arjun, Vera, or Anjani, please feel free to raise your hands. We're going to unmute you and then allow you to come in with questions. And I'm going to do a quick check on the chat. I think Shiv had left us some comments earlier, but I don't see a question so far. Anyone here who has a question? And if not, maybe perhaps I can, Deepa, I don't know if you've had a chance to look at Vera and Arjun's work in the past, but it'd be interesting if you had any thoughts, especially given the work that you're doing with social participation for member states and the guidance that you're developing. So any quick thoughts or comments?
Yes, sure. No, I mean, first of all, congratulations and hats off to both the colleagues in Brazil and in India, because this is exactly the kind of social innovation that we need more of. We know that, in many places, government capacity is limited, and we can't rely entirely on government capacity to provide the kind of comprehensive care and that comprehensive approach with communities. And what we need more of is more of this, of the kind of work that what Dara and Noura Health are doing. And in addition to that, we need that close link between such institutes or initiatives and government decision making on the one hand, and then of course that close link between such initiatives and communities on the other hand. And often what we see is that the link to communities is fairly strong, and the link to government decision making is a bit tenuous. But in this case, it seems like it works well both ways, and this is really the strength for me, of the initiatives that were presented, because if we can capitalize on what's going on in communities and understand what's going on within families, within within those, within families, communities, individuals. And if we can feed that information back up to state governments, to national governments, and ensure that it goes into programming decisions, that it goes into policy decisions, then obviously this is where we're then really making a push towards real primary healthcare. On another note, the Social Participation Handbook, it's finished, it's out. So I will put the link into the chat box for anyone who is interested. This is the WHO Handbook on Social Participation for Universal Health Coverage. It's basically, it's a guidance document for policymakers on that how-to of participation, because they struggle a lot. The capacities are very weak. And so this is sort of giving policymakers orientation to figure out how to, and how to think through all of those aspects that are really important in engaging with communities and feeding that capturing a voice into decision-making processes. Thank you.
Thanks very much, Deepa. And I think there are more questions, so we'll come back, and perhaps Vera and Arjun have questions for or comments for you, Deepa, and we can open up that discussion amongst all of you as well. But this is a specific question for Vera, and this is a question from Lovely Zega, who says that she wants to know how, with your tight budgets, how do you prioritize which family to help and which family to not help? If Vera, if you want to come in and answer that.
Yeah. Let me see if I understood well. Do you want to know exactly how, what are the criteria to choose a family to come to DARA headquarters? Is that right?
So the question is, let's say you have 2 families or 10 families, and do you have enough resources to help all 10? And if you do not have budgets to help all 10, how do you choose which families you will help?
That's a wonderful question. Thank you for the question. We choose the family with the worst scenario, the poorest among the poor. Is our, since the beginning, we understood that DARA wants to work with the poorest among the poor, because it's very painful to live in that condition. So inside the hospital, for example, we work with 2 hospitals, Santa Lagoa and Murillo. So there is a group, a triage group, nurses, social workers, doctors. If a family says, as a poor, I have everything, they don't come to DARA Institute. We choose family, very vulnerable family. If I have 10 families and I have budget only for 2, I will choose the poorest, the most vulnerable families.
Thank you very much for that, Vera. And the next question that we have is about the fact, and I think this references what Deepa was saying, that public-private partnerships are key. However, there are many, many challenges, right? What can be kept in mind to ensure that these partnerships are actually partnerships for public good? And yeah, any of you can take this. I know all of you have experience with public-private partnerships in different parts of the world. So who would like to go first?
I can take a stab at it and maybe hand over to others. So public-private partnerships. So that word partnership is really key. And I think this is where, partnership implies that the 2 sides have sort of an equal influence, power, information, data, all of that stuff. And this is where in many places it's not the case. We know that the private side sometimes has an upper hand in many ways, which better organization, better resources, etc. So, because these, in order to channel private resources towards public goods, or in our case, public health goals, we need the public sector to be strong. And if at the outset, the public sector isn't strong and that regulatory capacity isn't there, then obviously we know from the beginning that there will be that power imbalance, and there, we will end up probably channeling private resources not necessarily entirely to public good. So I mean, really at the core, the one thing that we can do is strengthen the public sector, strengthen regulatory capacity. That's obviously very easy to say, not so easy to do, especially when political will is weak in that area. We as WHO, we're pushing quite a bit for that at global fora like the World Health Assembly and other international fora for strengthening of public sector, for more public funds going into health, and to go away from an over reliance on private resources. So that's one thing that I think that's really important. Secondly, I think it's also to have a basic recognition of the imbalance of power and resources, because that is something that can then potentially be addressed if we know that from the outset that government doesn't have the resources to enter into, for example, a public-private partnership to run a hospital. Then it might be better to say, look, maybe we shouldn't go that direction, or maybe we need to bring in other actors on board that can help fill that gap a little bit. So yeah, I'm not sure if that entirely answers the question. It's a little bit unsatisfactory because I'm saying we need to do something that's very tough and very difficult. But in the end, that's really the direction that we need to go. Maybe finally, I'd like to say one thing. We need to think about the countervailing influence and power amongst the different actors in society. Private sector is obviously one big actor. Public sector government is another big actor, but we often forget that the big set of actors which is the public, which is the population, which is civil society. And smart government actors, especially local government actors, we have seen really good examples of where they bring on board civil society and community groups in a smart way to kind of provide a countervailing voice to what private sector might be pushing for. And that's one way to sort of leverage the power of the people, and if you want to put it into a cliche, but so there are little actions that one can do to try to broker a solution that is feasible and that's not only in the interest of private sector, but really is more going towards a public good. Over.
Thanks very much, Deepa. Just Arjun. Yes, Ranjani, go ahead.
Yeah, so if I may come in, I think what is critical when engaging with the private sector is really not to neglect or swipe away their interest in brand building. And I think there are some wonderful examples which emerged during the pandemic, wherein corporate social responsibility funds were pooled at a hyper-local level. With examples where these pools were made available at local government level so that they could be channeled into prioritized areas that the public sector, which was managing the pandemic, could then utilize. So that is one way of looking at engaging with the private sector, wherein we respect the fact that while they would spend money which is not driven by profit, as well as ensure that the money that is made available to the private sector can be channeled appropriately into prioritized activities. Thank you.
Thanks, Ranjani. Arjun, Vera, would you like to say anything, add to that response?
I can make a quick comment on how we work with government. I know that's a little different from the question in terms of the private-public partnership, but I think, taking off of Deepa's points, recognizing like where government and the public sector can really have, more of an impact and take more of a lead, and sort of creating scenarios also where we're bringing them on board and really trying to establish that ability to transition certain services, for example, or to really collaborate much more closely rather than in a sort of vendor-client type of relationship, but really build that from the start in terms of, for example, the fact that nurses, all the nurses that we train are government employees, and these are government sector nurses, 6,000 of them that we've worked closely with, and we've, I think, been able to make a dent with some states, at least in India, where there is a recognition of, at a systems level, how that's making a difference. And that's the piece that I think is just understanding the evidence and the impact that different stakeholders, in the context that you're working, are really looking for, and what some of those key pieces are that can help drive the overall agenda better.
Thanks, Arjun. Vera, did you want to come in on public-private partnerships?
The reality in Brazil is not very good in terms of private public partnership. For example, just once we receive, money, resource from the government. Normally, the companies, they support our organization. So we became public policy, as I told during the presentation, but it's not very easy because the bureaucratic practice of the government, they are so complicated in Brazil that normally we gave up, to tell the truth.
And I think where that's probably not just in Brazil, but in several parts of the world where it is challenging to engage with the public side. And I think Shiv had put this on chat, is that I think social entrepreneurs, social innovators, or as broadly what Deepa was calling us, civil society, right? I think the public voice, entrepreneurs, enterprises, we have the opportunity, I think, to innovate and work with as best as we can with both the public and the private side and navigate that to actually ensure that we achieve what we want to see in terms of the transformation and achieving SDG 3. Yes, Vera, you had a point.
Yes, Shama, I have an idea because, for example, I don't know, we are talking with the federal government in the moment, because we want to become a federal, practice all over Brazil, because we proved the concept. We are working during 30 years, and we are now working with the social workers in our capital, Brasilia, to establish the methodology being done by the government all over Brazil, through our social center. We have 8,000 social centers all over Brazil. But I think if WHO will be able to talk with the government in Brazil and to emphasize how important it is to take into account the social determinants of health, the comprehensive way to see health, that will help a lot. Maybe this, WHO or other organization talking with the federal government, trying to do advocacy to our cause may help a lot.
Thank you, Vera, for that plug. And I think that's exactly why we're talking about this network, right? Networks across the globe where social entrepreneurs working in primary healthcare, whether that's in Brazil, whether that's in India, whether that's in Bangladesh or in South Africa or in Nigeria, anywhere in the world, I think the bringing together and ensuring that what's already happening in the country, recognizing that and actually making that a reality where we can bring both public, private and civil society, especially people's voices, into that mix, I think is really what we're trying to do in terms of this network, because there is not enough of that learning. It still tends to be a very supply side focused or, facility medical care focused sort of approach. And we're sort of nearing the end of this hour. I don't see any questions on the chat. Anybody who'd like to make a comment or want to raise a hand, we'll take one last sort of set of comments or reactions before we head into closure. Anyone, last questions, or anybody else from our panelists who'd like to make a comment? No? All right. So yes, I think and like I said earlier, right, what Noura Health or what Dara is doing is just very, it's just exemplars. There are so many people out there, and we want to be able to learn and actually push for the acceleration for comprehensive primary healthcare over the next 8 years. If I can request my colleagues to put we have a very quick form. If you'd like to be part of the network, we're going to shape the network together. That's what we will do with the Catalyst 2030 platform over the next year, whether it's learning, whether it's advocacy with our governments, whether it's engaging with WHO or others who may be relevant to actually get attention on this issue, or raising funds because philanthropy or monies, resources are required to actually get a lot of the work done. If we can have that on the chat, and if I can request all of you to actually respond to that, really appreciate it, and we will be in touch with you. And just to summarize, I think we've heard enough today that comprehensive primary healthcare saves money, not just for individuals, but for society. It avoids admissions and builds a healthier and stronger society. There is compelling evidence, right? Even economic benefit is possible. For example, something as simple as $1 spent on immunization is estimated to return $44. So our call to action here is for social innovators in primary healthcare to be working together, learning and accelerating action towards SDG 3, working, of course, with the public, the larger private corporate sector, as well as policymakers. And if you're an innovator in PHC and you're here, please join the network. We'll grow together. And if you play any other role in the health system and want to engage, do sign up, do join the network, and we'll build it together. Thank you, everyone, for joining in. We're at 8 p.m. and thank you once again, and look forward to being in touch with all of you. Thank you to Arjun, Vera, Deepa, Ranjani for joining us. Thank you also to the team here behind the scenes. We had a little bit of trouble, but I think we managed overall. So thank you, Florancia, Aditi, Harshita, Deepa, and Mishri from the Catalyst 2030 network as well for all the support in bringing this together. Have a great day. Have a great evening, everyone.